Okay, so, so it doesn't, hi there. This is my first time with our new YouTube, not Periscope version of our Pathcasts, which I guess they're now called. So you can't see my face, which is just as well. I have a terrible cold, but you can hear me sniffing probably. And I can't see who's on or where they're from, or just it's a blind thing. All right, so I'm talking to a large, infinitely dark, empty space, which is a little weird. If there are residents in the room that have questions, don't hesitate to interrupt me if I'm not being clear about things. So I wanted to talk about PBC, formerly known as primary biliary cirrhosis, because the name change is confusing to people, and also because we have some new ways of doing diagnostic assessments of biopsies that have not yet made it out into the mainstream, although we have published on this. And I thought I would share some of this because I think it's really helpful. So first off, the name, primary biliary cirrhosis. Perfectly good name. Why was this changed? Well, the big issue is that the word cirrhosis has a couple of connotations that are really inappropriate as a general term. In fact, a group I'm part of called, informally known as the Elves, that's a long story, I'll spare you for this morning, have published a paper also known as the International Liver Pathology Study Group. We've published a paper called Beyond Cirrhosis, which is worth taking a look at. If you Google my name and cirrhosis, it's probably the top thing that will come up. The argument we're making is that the word cirrhosis is sort of like honeycomb lung. When we had no treatments for liver diseases, and all end-stage people who died of liver disease seemed to have this nodular liver, one word was sufficient because it didn't really matter to distinguish them. But now we have a variety of well-characterized diseases, many of which have treatments associated with them. So the old implication that cirrhosis meant you were going to die, and the later implication, die or survive by getting a liver transplant, really no longer holds. But in the popular imagination, including amongst doctors, cirrhosis is thought of as an end-stage liver, and it is not necessarily an end-stage liver. In fact, we now know very clearly that cirrhosis can regress to non-cirrhotic stages of disease. This was first notably demonstrated by Ian Wanless from Canada, but is now sort of understood that, for example, after curative therapy for hepatitis C or suppressive therapy for B, that cirrhosis can regress. So the connotation of it being end-stage liver disease is wrong. And so that's a problem. And patients with PBC, who often refer to themselves in the United States as PBCers, while they're attached to the initials PBC, the fact is that much of end-stage PBC, if it ever gets that far, is not in fact cirrhotic. Some of them become cirrhotic if there's such generalized bile duct loss, and those livers are generally large, green, and very nodular. But more often, patients are transplanted in a pre-cirrhotic stage for portal hypertension. And why the portal hypertension develops in these patients really isn't clear. One of the big mysteries that's waiting for some young pathologist to study out there in the world and figure out. We have lots of unanswered questions. But so cirrhosis is a misnomer because often end-stage PBC livers are not in fact cirrhotic. And the word cirrhosis implies that you're going to die of the disease, which is certainly not true, particularly now that we have ursodeoxycholic acid as a treatment that slows progression, if not prevents progression of disease. And the third thing is that in the popular imagination, if you say cirrhosis to people walking down the street, and ask them to associate a word with it, the first word that pops into their mind is alcohol. And so people with cirrhosis as their disease are often assumed to be alcoholic by people, certainly in the United States, certainly in Europe. So those are all issues that recommend a change, at least in this disease. And the leading PBC clinicians on the planet got together last year and decided to change the name for all these reasons. And they published the change of nomenclature in a variety of journals. It's easy to find. All you do is search on primary biliary cholangitis, and that will come up. So the pathologists were not consulted on this name change. I'm not sure we could have come up with something better, because clearly from the patient advocacy standpoint, they really wanted the letters PBC. This was the patients driving this issue, which I think is really important and really powerful. But primary biliary cholangitis is a little bit weird, because what cholangitis isn't biliary? So, you know, it's a little bit repetitive and redundant. But that's the way the name has been changed. And so now primary biliary cholangitis, PBC, still PBC for all intents and purposes. So that's the name change. We just accept it and keep going. So most of you know, I'm sure, that PBC is usually seen in women. Not always, sometimes men get it, but it's predominantly women, predominantly middle-aged to older, and often associated with autoimmune diseases that are typical of middle-aged to older women. Scleroderma, Hashimoto's thyroiditis, Crest syndrome, Sjogren's syndrome, etc. I'm sorry for the background noise, but some printer in here just turned on. Hopefully it won't go on for hundreds of pages. Serologic markers, anti-mitochondrial antibody is the classic, but it's not positive in everybody. I don't let its absence prevent me from diagnosing PBC in a biopsy. They may also have anti-smooth muscle actin antibodies, anti-nuclear antibodies. So any combination of these. AMA predominates, certainly. There may be a specific disease, a pathophysiology role for anti-mitochondrial antibodies. There are several lines of investigation that suggest that, but often patients do not have it, and that does not prevent a diagnosis of PBC. The bile ducts involved are only the medium to smallest ducts in the liver, so it is not diagnosable by imaging, MRCP or ERCP, because the larger ducts you see with those techniques are all intact. So a needle biopsy is the way the diagnosis is made and confirmed. And that's what I want to focus on in this talk. So typically, these are known as the Scheuer stages. Peter Scheuer, my mentor at the Royal Free Hospital in London, was one of the early pathologists writing on PBC, along with his hepatologist, Sheila Sherlock. And so these are the stages, not as in staging of viral hepatitis that you're used to doing, or fatty liver disease that you're becoming used to doing. This is the stages of how the disease progresses. It is not a histologic hallmark of advancing liver disease. Because PBC is very patchy, if you were to do biopsies at the same time of multiple spots in the liver, you would see all different stages of disease, probably, a mix. And when you get explants, you can find areas that look normal. You can find areas that have a little scarring. You find areas that look cirrhotic. So it's highly variable. This is a way to think about the progressive injury to the liver as it's happening in any given site. First, there is bile duct injury or loss. And the classic diagnostic feature we got a little feedback on that. That's not very helpful. So here is a diagnostic duct destructive lesion. There's a bile duct being chewed up by a granuloma with a cuff of inflammatory cells. They're predominantly T cells surrounding it. If you see this in a biopsy, this is a diagnostic primary biliary cirrhosis lesion. You virtually don't see this in anything else. You can have mimics in sarcoid, but usually the duct is being pushed to the side. It's not under attack. You may see it in very, very rare, very uncommon drug toxicities or paraneoplastic syndromes. In general, if you see this, this is diagnostic of PBC. Granulomatous duct destruction. Here's another granulomatous duct destructive lesion, but this highlights that patchy aspect. Why is it that this part of the bile duct is completely intact, and then you come along here and it's being chewed up? What happens at this juncture that changes this from an uninvolved duct to a critically injured duct? And we don't know the answer to that question. This is also a diagnostic duct destructive lesion. If you see this on a biopsy, you can say primary biliary cholangitis, parentheses, diagnostic biopsy, close parentheses. That was Peter Scheuer's convention, and a lot of people do it that way. If you don't have a diagnostic duct destructive lesion, you would say features compatible with PBC. What would such a duct look like, a biopsy look like? Well, here's a portal tract, there's an artery, there's a little bit of a vein, and there's a lymphoplasmacytic infiltrate here, and there's no bile duct. So this is duct absence, but it isn't a diagnostic duct destructive lesion. This could be absence from primary sclerosing cholangitis. It could be a drug toxicity. It could be a paraneoplastic syndrome. This were post-transplant patient. It could be vanishing bile duct syndrome of transplant. It could be a GVHD lesion in someone who's had bone marrow transplant. So it is not diagnostic of PBC. If the clinical features all point to PBC, it's a 62-year-old woman, AMA positive, alkaline phosphatase 8 times normal, ALT, AST minimally elevated, and antimitochondrial antibody positive, which I may have already said, antihistamines on board, sorry. Then you see this and you can say compatible with PBC. Notice that there are a few EOs. Hans Popper, the founder of Mount Sinai, one of the founders of Mount Sinai Medical School, and certainly the giant founder of the whole field of hepatopathology, said that you always see some EOs. If you don't see EOs, it's not PBC. But I've never had a case where that was actually a critical question because they're always there. And also plasma cells. So we think of plasma cells as being a hallmark of autoimmune hepatitis, but you see them in PBC as well. And I think it was Lisa Yarian who did some work. I'm not sure if this came out as a paper. I know it was an abstract showing that in autoimmune hepatitis, the plasma cells are IgG positive, and those patients have elevated IgG in their serum. In PBC, IgM is elevated, so that's another serum test. That's a hallmark of PBC. And the plasma cells in PBC are IgM positive if you do immunostaining. Those are difficult stains to do to keep clean enough to see what's positive, what's negative, so I don't rely on them. Well, what happens if you injure a bile duct? Then you get a ductular reaction. It's a stem cell response in some fashion. And so here's the cholangiocytes proliferating along the margins of the portal tract stroma. That's a ductular reaction in PBC. Here's an artery. There's no bile ducts to go with it. So this is a stage 2 PBC lesion. It is not diagnostic. Only the stage 1 duct destructive lesion is diagnostic, but this is compatible with stage 2 PBC. And then stage 3 to 4, this is why this doesn't serve as a staging scheme the way staging serves in viral hepatitis, for example, because stage 3 is anything from portal fibrosis to a transition to cirrhosis. And then stage 4 is actually established cirrhosis. So the scarring aspect is a whole huge spectrum in stage 3 that is not broken down into individual bits and pieces. Yasuni Nakanuma has created a new staging system for PBC. If you Google Nakanuma, N-A-K-A-N-U-M-A, PBC staging, that paper will come up. And some people are using it clinically. It relies on some tests that we don't do here, so I do not as yet use it. And PBC, oh, this is a fuzzy picture, I'm sorry. Typical biliary cirrhosis at low power, you have funny shaped pieces. They're like jigsaw puzzle shapes rather than round that you usually see in chronic hepatitis. And they have a peripheral halo that's septal edema, the ductular reactions, collate stasis of hepatocytes at the margin. And at low power, this could be chronic duct obstruction. It could be primary biliary cirrhosis. It could be primary sclerosing cholangitis. To make the differential, because they all look the same if they go to this end-stage cirrhosis or late-stage cirrhosis, I should say. If there are no ducts missing when you go to higher power, then it looks like chronic obstruction. If it's all size bile ducts that are involved, then you're probably thinking primary sclerosing cholangitis. And if it's only the smallest ducts, it's probably PBC. although small duct variant of PSC is an issue too. All right, that's the preamble. So the first case I want to show you is a 45-year-old woman who has slightly elevated ALT, 46, AST normal range, 23, ALK phos 417, ANA negative, anti-nuclear antibody negative, anti-mitochondrial antibody positive, 1 to 160. And so this case, now, right. So we switch to Google Hangout. No. People are coming in from Facebook. And why is this not? We're working on getting the image, sorry.
Okay.
It's blinking.
Yeah, it should be okay.
It should be okay, but it's not yet. Let me go to higher power.
Right there.
Yeah.
Just the,
there.
Is the light too high?
Yeah.
Oh, there we go.
Yeah.
So the light was too high. Okay. And there's a little lag, so focusing is a little weird. Okay. So so low power, we see that portal tracts are often blue. This one's very cellular, but it's blue to pink. That's sort of an obvious lesion to look at, but I want to scan over the low power first. And so we see that a lot of portal tracts have very dense blue infiltrates. At low power, you'd be wondering, could this be a viral hepatitis? You'd be wondering about PBC. Drug toxicities are always on your list. But let's go to where the money is. This lesion here. And so this looks like a granulomatous lesion expanding a portal tract. And do I see a duct in the middle of it? Not really clearly. So this is the kind of thing where I'm going to want to go down onto deeper levels and see what there is to see. But I'm suspicious of PBC now, though this could be sarcoid, for example, or AFB. You know, could this be tuberculosis with a granuloma in the portal tract? Sure. Here's a portal tract, bile duct intact. That doesn't mean it's not PBC because of how patchy the disease is. Here's a portal tract with inflammation and no duct. So there seems to be some duct absence. And over here, a beautiful diagnostic duct destructive lesion. So there's the bile duct. And you can see that there are inflammatory cells breaching the basement membrane. Early studies of by electron microscopy of PBC showed that the histologic hallmark of the duct damage was a fragmented basement membrane. And if you do a PASD stain on a slide like this, it really highlights that. So there's your diagnostic duct destructive lesion. And see how this doesn't have the granulomas. It's mostly lymphoplasmacytic infiltrate. So you don't have to have the granuloma, though you often do. Okay? So this is an easy case, PBC. And now I just say early versus late stage. This would be early stage because there's very little in the way of scarring when we looked around. If I see fibrosepta or nodularity developing, then I start to call it late stage. The staging is not important for the most part for clinical assessment. And so I could show you more slides of the same case, but the diagnosis is made.
Do you use this thing CK7 19 on these cases?
Well, I haven't gotten to the issue. So I'm being asked if I stay in keratin 7 and keratin 19 on these cases. I haven't gotten to that issue yet. That is next. No, it's actually not next. It's one down. So this is case 2. I'm going to show you. So that's a straightforward case. The clinical is straightforward. The biopsy diagnosis is straightforward. It's a diagnostic duct-destructive lesion. There are many of them in the case, actually. So this is a 52-year-old woman who has elevated serum transaminases and alkaline phosphatase, who is on Lipitor, cholesterol-lowering agent. So the question is she having a Lipitor reaction in her liver, which is possible. It's fairly uncommon, but everyone worries about it. But interestingly, her sister has primary biliary cirrhosis, and she's got a history of alcohol use. So there's lots of reasons why she could have something going on in her liver. And we'll come back to this in a moment, or not. So there's a little fat in the liver, that's clear. Mild steatosis, mild to moderate steatosis. But then, so there's a parenchymal granuloma. And you see these in PBC. Does someone have a tissue or a napkin? My antihistamines are not working. Thank you. So you see these parenchymal granulomas. They very rarely have giant cells, though you can see giant cells sometimes in PBC, but it's pretty uncommon. So it's not likely you're going to mistake this for sarcoid. But that's an interesting little finding. But non-specific. And then you have this lesion here. This is interesting. So here's a duct that's bigger than you would see involved in PBC. But this duct is sort of at the upper limit of what you would see in PBC, and it looks like there's some inflammation around it. Is that a diagnostic duct-destructive lesion? No. But this tells me this is a duct I'd want to look at on a deeper level. And so I got, normally we get deeper levels on our cases. We get 3 H&Es on all our liver biopsies. We get a PASD, an iron, a trichrome, and a reticulin. So we have other levels to look at, looking for a diagnostic biopsy, a diagnostic lesion. In this patient, there were none on any of these slides. So do we stop there? There was no clear bile duct loss. There was only this sort of stuff. So this is a completely non-diagnostic biopsy. There isn't a clear reason for her abnormal liver tests. But what Peter Scheuer always told me to do is, if you get a case where you're clinically suspicious of PBC, and in all your initial stains you don't get a diagnostic duct-destructive lesion, do 6 deeper levels. And when I do that, I find about 50% of my cases, sure enough, you find a deeper, you find a diagnostic duct-destructive lesion deeper down. And so we ordered 6 deeper levels on this case. And here's a portal tract, not much going on there, non-specific inflammation, bile ducts intact. Here's a portal tract, bile duct still intact. Portal tract, bile duct still intact. So there's really nothing here to give us PBC until we get to, oh, there's that large bile duct again, and right next to it, diagnostic duct-destructive lesion. That's how patchy PBC is. And it's like that image I showed you before. This is not that same case. That picture was years old. Relatively intact bile duct over here, and then it's being chewed up by this vaguely granulomatous duct-destructive lesion. Diagnostic early stage PBC. Okay? So you do your regular stains. You try and find a diagnosis. If you don't see it, get deeper levels. Peter Scheuer recommended 6 deeper levels. That's what I do. And in this case, it made the diagnosis. So that's straightforward. Now, one of the smart residents here asked me about keratin staining, keratin 7 and keratin 19 staining. And the reason for asking me about that is what I'm going to show you now. So what do you do if the deeper levels don't work? Used to be that's where we had to stop. But now, this is unpublished work. There are some people who have talked about keratin 7 staining in chronic biliary tract disease, and hepatocytes will start to become positive with chronic cholestatic injury. Looks like this. So these are not biliary structures. These are hepatocytes that look totally normal by H&E. But when you stain them in chronic cholestatic liver disease, you get variable degrees, a small amount to a large amount to confluent areas where the hepatocytes have turned on the keratin 7 gene. We don't really know why this happens. This is another question that's waiting for some young pathologist to come along and figure it out. One suggestion made by Jim Crawford, who's now at Northwell Hospital System on Long Island. He's one of the International Liver Pathology Study Group I mentioned, and he's a scholar of biliary stuff and cholestasis stuff. And he points out that bile is actively transported from the basolateral membranes to the apical membrane of the canaliculus in hepatocytes. And so when you have a cholestatic hepatocyte, that has to be reversed into retrograde flow, and maybe keratin 7 is part of the cytoskeletal rearrangement to get retrograde bile flow from the canaliculus back out into the serum. So that's a reasonable hypothesis. No one has studied it as far as I know. So when you have any chronic cholestatic liver disease, if you do a keratin 7 stain, you see this. So if you do a keratin 7 stain on early stage disease and you see this, you can infer that it's probably cholestatic liver disease. So that helps you to confirm that there's a cholestatic disease in a patient like this. In later stage diseases of all kinds, you start to see this because in later stage diseases, you start to get cholestasis. But in an early stage biopsy like this one, like these two that I've shown you, this is the pattern that you'll see. And you wouldn't see this in early Hep C, Hep B, early alcohol, early NAFL. And so here you have hepatocytes staining for keratin 7. And there's a bile duct, and there's a bile duct, darkly staining, because biliary cells stain for keratin 7. But here are the periportal hepatocytes that are keratin 7 positive. Chronic cholestatic pattern. Okay. What else can you do? This is where it gets fun. So people who know me in the liver world know that I am sort of obsessed with the canals of Herring. These are the interface between the biliary tree and the canalicular system draining bile from the hepatocytes. Romo Saxena, Jim Crawford, and I published this review with this image back in 1999, accompanying a paper in which we first described the actual structure of the Canal of Herring. This idea that the Canal of Herring was at the interface, the limiting plate, of hepatocytes with the portal tract stroma is based on drawings Herring, a German anatomist in 1857, drew with his imagination of what they looked like. He had proven through functional studies, dye-excretion studies, that the canalicular system communicated with the biliary tree. He inferred there had to be a link like this, and he drew pictures that looked like this. But no one had ever actually seen it under the microscope or reported it if they did. I had this normal biopsy stain for biliary cytokeratins, and this was published in that paper in 1999. And here's an isolated, small, round cell, positive for biliary keratins, away from the portal tract. This is a normal human liver biopsy. Serial sections show that it's a chain of cells that approaches the portal tract. Here's another chain that appears and starts to approach it, and they come together and join into a tiny little twin of a bile duct. So it turns out these little cells are cross sections of the Canal of Herring, and the Canal of Herring doesn't stop at the limiting plate. It extends as much as a third of the way into the hepatic globule. This turns out to be one of the most important stem cell niches in the liver, and that was the focus of the paper that published this. We would redraw the diagram to look something like this now. So another way to look at it, if this is the old normal liver lobule, this is the new normal liver lobule. And you can't really see these without doing the immunostains. Keratin 19 is the best stain. You can see it on keratin 7, but then you may have those hepatocytes that are getting in the way, so they're hard to recognize. EpCAM also stains these structures. So keratin 19 is the one I use routinely for clinical purposes because the lab has it working. Turns out that the first computer 3D reconstruction ever performed in the liver was done by Peter Scheuer with Shoji Yamada, who was visiting the Royal Free from Japan. And this is PBC. And here's a bile duct, and here's a granulomatous duct destructive lesion. And they saw the canals of Herring. But since they didn't know what the canals of Herring looked like, they didn't say these were the canals of Herring. They said, this is the ductular reaction of stage 2 PBC, creating a new channel to the bile ducts. But now we know it's exactly the opposite. This is the pre-existing canal of Herring, giving rise as a stem cell response to create a bigger anastomotic interface with hepatocytes to drain bile after the obstruction. So that's actually a beautiful 3D drawing of what the canals of Herring look like, made 12 years before it was discovered what they actually look like. Romo Saxena and Mike Hitiroglu, he's now in, he was in New York at the time, but is now in Thessaloniki, and Swan Thung at Mount Sinai, my mentor in after Peter Scheuer. She's my professional mother, as she likes to say. I like to say she's my professional mom. So the four of us did this study. Since the question is obvious, since PBC involves the smallest ducts, does it involve the canals of Herring? And so here is a typical portal tract in a relatively normal biopsy. I'm not going to go into this, there's not time, but basically see how many canal of Herring profiles there are around this portal tract. 1, 2, 3, 4, 5, 6, 7, 8. So they're not hard to find. They're really easy to find. They're all over the place. And when you quantify them, the number of canals of Herring in normals ranges from 3 to 16 canals of Herring per portal tract. So at low power, you see them, these little black stars in the field surrounding each portal tract. So what we did in this study is we only took early stage PBC livers up through mild portal fibrosis. I didn't want to have any architectural distortions that might confuse things because I didn't know how to count canals of Herring in such cases. So, and then what we did is these stages are not the stage of the biopsy, it's the stage of each individual portal tract. So in every biopsy, we had some that looked normal, some that looked like duct destructive lesions or just absence of a bile duct, some that had a little ductular reaction, some that had a little fibrosis. And when we counted the canals of Herring around them, the surprise finding was that the fewest canals of Herring were in the totally normal were around the totally normal appearing portal tracts. So before you have a bile duct lesion, you have loss of the canals of Herring. And look at that difference there. This was obviously clinically significant. So I started paying attention to biopsies over the years. It took about 12 years to accumulate a bunch of cases where clinically the patient was PBC. Histologically, I could not prove it. I did the deeper levels. There were no diagnostic duct destructive lesions. There were no missing bile ducts. There was only a little bit of nonspecific inflammation in portal tracts. But when I did the keratin 7 and keratin 19, the keratin 7 showed cholestatic type hepatocytes, and the keratin 19 showed absence of canals of Herring. And so we published this in Hepatology in 2013. I always liked the name minimal change, glomerular, oh God, antihistamines. What's it called? Minimal change kidney. Oh, minimal change disease, right. I'm thinking there's some glomerulus word in there. Minimal change disease. I don't like kidney. I do liver. So I wanted to have minimal change PBC. And it's basically a nearly normal biopsy with minimal inflammatory changes, no duct loss, level after level after level. But when you stain it, you see that there's a loss of bile ducts. And so in these cases, I quoted the early paper Roman Saxena being first author, so I could search on her name later when I wanted to study these cases. And over the course of about a decade, we got 10 cases. We had matched clinical subjects who had early stage biopsies that were diagnostic. And it turned out that they were clinically identical. Their responses to urso deoxycholic acid were clinically identical. The rates of overlap autoimmune hepatitis were identical. The rates of associated extrahepatic autoimmune diseases like Hashimoto's thyroiditis were identical. And so we published this in Hepatology as this is, I'd like to say it's a diagnostic lesion. I don't think we can say that yet. Yasuni Nakanuma in Japan, again, has studied some data, has published a study which confirms this kind of finding. But I think we need a little more publications to confirm that it's actually diagnostic. This is all the comparative clinical data. Same range of AMA, ANA, SMA positivity in the matched controls and the Canal of Herring lost biopsies. And this is the data from that paper. And again, minimal change PBC. Look at that. It's not subtle. At low power, normally you see canals of Herring around the portal tracts. If you have to count portal tract by portal tract, you see one here or there, but that's it. That's the diagnosis. So here's a case. This is a 65-year-old woman, GGT 310, alkaline phosphatase twice normal at 280. ALT 42, AST 34, slight elevation, ANA positive, anti-smooth muscle antibody positive, anti-mitochondrial antibody negative. And this biopsy looks pretty normal. There's some scant inflammation. The bile ducts are present. The lobule looks unimpressive. This portal tract has a little bit of inflammation, but that's totally nonspecific. Maybe a touch of interface hepatitis there, maybe a touch. Normal, scant inflammation, etc., etc., etc. Clinically, PBC. Histologically, not so much. Right? So let me remind you of what a normal Canal of Herring profile looks like. Canals of Herring, easily identified around every portal tract between 3 and 16. You can see these at low power, dark little dots. This is the keratin 7 in this case. Oops. Oh, sorry. I got it. There we go. So we have that cholestatic pattern of hepatocyte staining, right? So we can say chronic cholestatic liver disease. But looking at this, we still don't have any duct loss. The duct's present. Duct present. No inflammation. Duct's present. But we can say some degree of chronic cholestatic liver disease. And then we do the keratin 19 stain. And here's a portal tract. Maybe there's one canal of Herring, one per portal tract. Here's a tiny ductule, no canals of Herring. Here's a canal of Herring. There's probably a portal tract underneath here, so that's one. There's one. None. Oh, there's one. None. One. That's a ductule. See, it has a little lumen. None. So, at less than one canal of Herring per portal tract in this biopsy. So we could sign this out confidently as features compatible. I can't say diagnostic yet. There's no consensus in the world that this is in fact a diagnostic lesion. That may come in the next few years. But I can certainly sign this out as marked loss of canals of Herring, compatible with or suggestive of primary biliary cirrhosis. Working with Rochelle de la Cruz, who was from the Philippines. She's back there now, but we're working on a paper she did while being with me as a fellow for a year and a half here in New York. We did keratin 7 and keratin 19 staining on early stage biopsies of a wide range of liver diseases, round up the usual suspects: drug toxin injury, Hep C, Hep B, alcohol, fatty liver disease, PSC, PBC, acute duct obstruction, maybe some other things. And doing keratin 7 and keratin 19 showed that in early stage biopsies, keratin 7 positivity in hepatocytes distinguishes cholestatic liver disease from non-cholestatic liver disease. And within that group, keratin 19 staining, loss of canals of Herring like this is PBC. PSC, you actually see more canal of Herring profiles. And in all the other diseases, you do not see loss of canals of Herring. So I think this is a useful diagnostic tool. When you get a biopsy where the clinician is sure it's PBC or really suspicious it's PBC, and you have a biopsy that's nearly normal looking. And this is an increasing situation. I think the sensitivity for PBC is higher than it used to be 10, 20 years ago. So more biopsies I get for PBC are like this than later stage diseases. They're being picked up earlier. And so what I do is I look at the levels that I have, 3 H&Es and the 4 special stains, whatever you have at your institution. If there's no diagnostic duct destructive lesion, I don't stop there. I do 6 deeper levels. I do 4 of those H&E, and I do 1 keratin 7 and 1 keratin 19. That's Peter Scheuer's 6 deeper levels. If I don't see a diagnostic duct destructive lesion on any of those, I look at the keratin 7 to show that it is compatible with chronic cholestatic liver disease. If that's negative, it's probably not PBC, at least not by the data that we're putting into our paper. And then I look at the keratin 19. If I see canals of Herring, it's not PBC, it's something else. But if I don't see canals of Herring, if I have to search for them the way I did in this biopsy rather than seeing them obviously at low power, then I'm confident in saying that's a patient that has PBC. And as our study and published in Hepatology shows, they respond to URSO like ordinary PBC patients. So minimal change PBC. By H&E, it can look virtually normal. Okay? Any questions for either in the room, or how do we get questions from outside the room, if we can?
We have already sent a message, so Emilio is working on it, so maybe we will get some feedback. No questions so far from outside.
Any questions in the room? Yes.
So, I just try to clear out some of the definition between the stage 1 PBC and minimal change PBC.
So the question is clarifying minimal change PBC from stage 1 PBC. This seems to be a pre-stage 1 lesion, which raises a really interesting question. Everyone presumes that the initial injury in PBC is the duct destruction. But here we're showing no duct destruction, but the canals of Herring are gone. What happens to them? I don't know. You don't see inflammation where they used to be. You don't see EpCAM positive hepatocytes, which my work and the work of a few other folks has shown that EpCAM positive hepatocytes are derived from stem cells. So could the canal of Herring, which are stem cells, have differentiated into hepatocytes? But I'd expect to see EpCAM positive hepatocytes if they did that, and I don't. Doesn't mean that's not happening. I just can't see it yet. Do they undergo apoptosis? How do you look at that if they're not there anymore? But one of the better mouse models for human PBC is one in which you get pH alterations in the bile. And we know from Alpini's work looking at pathophysiology of cholangiocytes that the small cholangiocytes are in part responsible for modulating pH of bile. So the canal of Herring, bile flows past it, and the pH is being modulated at that level. So is it possible that you lose the canals of Herring as the actual initiating injury, that alters the pH of the bile, leading to damage to cholangiocytes, and that sets up the duct injury. So theoretically, this is stage 0 PBC. That's why we call it minimal change.
And the bigger machine, the beaker shows, even less herring staining compared to stage 1 disease.
Right. Yeah. So the canals of Herring come back. So there must be persistence and then produce the ductal reactions, as Peter Scheuer's structures show. So we don't really know what's going on at this point, and it's really ripe for investigation. I think that's maybe the more important thing. The clinical import of this is this can be helpful to make a diagnosis. The scientific import is we have a window on the earliest possible stage of injury. Can we figure out what is actually going on? It seems we've been looking at later stages in all of our scientific efforts. Any other questions? It's really easy, right? What's hard?
Hard is to say that it's PBC, not chronic hepatitis.
Well, but then you do the keratin 9. So he says, what's hard is, how do you know it's not chronic hepatitis? You have inflammatory cells in the portal tracts. You don't have duct loss. Do the keratin 19 staining and the keratin 7 staining. Viral hepatitis, you will not have keratin 7 positive hepatocytes in the early stage of disease. Keratin 19, you will have normal canals of Herring in hepatitis C or hep B early stage. They'll be gone. Gone in PBC. Remember this picture. That's what normal looks like. It's not hard to tell they're missing. If you want to get a little better handle on this, take any liver biopsy that is not PBC, normal or early stage disease, early stage hep C, early stage fatty liver disease, the most common things you have, and do keratin 19 staining on 1 or 2 of them, it'll be really obvious. Oh, it looks like this. So when they're not there, it's really obvious. It's not a subtle finding. So it's easy. It is both simple and easy, which is not always the case. Try meditating. It's simple, but it's not easy. Diagnosis of PBC, both simple and easy, if you use keratin 7 and keratin 19 and deeper levels. Okay, are we done?
We have one more page, right?
No, that's it.
Oh, that's it?
That's it.
Okay.
All right, thank you very much.
Thank you.